The challenge to all ophthalmologists is to get a complete continuous curvilinear capsular rhexis in a case of mature intumescent cataract. Due to raised intralenticular pressure, chances of rhexis runaway, extension, and Argentinian flag signs are always in the back of our mind. This video depicts a novel yet simple technique for handling mature intumescent cataract. All is required is a 26 gauge needle and a 5 ml or a 2 ml syringe. Small side ports for closed chamber maneuvers is first made. After injecting air bubble to protect the endothelium, the anterior lens capsule is stained with trypan blue. It makes the capsule thicker and visually more helpful. We take the 26 gauge needle with some saline filled in the syringe in case the capsule gets stuck and you want to flush back like a reflex in phaco. As you tear slowly, start aspirating in the bevel down position, as the anterior lens capsule will get stuck if the bevel is facing upwards. When you start aspirating, the liquefied cortex and the intralenticular pressure decompresses and the chances of an Argentinian flag sign is nullified. Once you aspirate the liquefied cortex, try to tap the lens so that fluid trapped beneath the nucleus comes out anteriorly. Once the aspiration is done, this nucleus and the anterior lens capsule behaves like any other cataract, helping us to get the desired size and shape of the rhexis. Keeping in mind, the anterior chamber should be completely filled with viscoelastic at all times. For hard mature cataract, this technique can be preferred where you have cataract with liquefied cortex, where the chances of rhexis to run away or tear or extend are very minimum or nil in this technique. The scariest cataracts are the intumescent cataract, where the intralenticular pressure is very high and the chances of extension is the maximum even after the first nick. As you can see, the amount of liquefied cortical matter being aspirated in the 26 gauge needle slowly and gently. This simple step ensures the intralenticular pressure has been brought down drastically and the chances of an Argentinian flag sign is almost nil. Once that step is done, the rhexis can be initiated with a cystotome or a capsule rhexis forceps. The shearing and the ripping force should be used together so that the rhexis is always pulled towards the center of the nucleus. The size of the rhexis will also be adequate and make sure that the anterior chamber is always filled with sufficient viscoelastic. In some of the intumescent cataract, where the nucleus is very soft, even after aspirating in the central, you will not be able to continue with the rhexis because of loss of counter traction. So you take the needle, aspirate around the periphery, and then after making a clear corneal entry, using a forceps, you continue the rhexis. Always make sure you always hold close to the margin of the point of tear. In cases where the rhexis is slightly small but big enough to complete the phacoemulsification without damaging the margins of rhexis, the IOL can be placed and then the rhexis can be extended by making a linear cut using a Vana scissors, and then with a micro rhexis forceps, you can extend the rhexis to the desired amount till the edge of the IOL, so as to prevent any anterior lens capsule phimosis. For such demanding patients, such good postoperative outcomes are possible. This is a novel, simple, cost-effective technique compared to many of the laser-assisted capsulorhexis procedure. Thank you very much. Hope you enjoy the video.